Thank you all for joining us today for another episode of our podcast, Moving to Value Unscripted. My name is Dr. John Rodas, and I'm a recovering ex-hospital president and am proud to be the president of the Moving to Value Alliance. The Moving to Value Alliance, MTVA, a 501c3 nonprofit, is a multi-stakeholder grassroots organization whose purpose is to foster a community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. I want to thank our members who make this presentation possible. We'd like to give special recognition today to our trade member, Sohn Health. We are joined today by my fellow board member, Dr. Steve Schutzer, and MTVA Executive Director, Laura Watson. Dr. Schutzer, a nationally renowned arthroplasty surgeon, is one of the founders of MTVA and is the co-founder and president of Upswing Health. Laura is a journalist with experience reporting on healthcare, antitrust, and regulatory news. Our special guest today is Olivia Deitcher, founder and CEO of Zest Dermatology. Dermatology is the fastest growing segment of specialty drug spend, and Olivia witnessed the challenges of dermatology care as a patient. She founded Zest to be part of the solution. Zest Dermatology is a virtual first dermatology clinic that focuses on comprehensive care for chronic autoimmune conditions, delivering lasting clinical outcomes and reduced prescription costs. The high-touch model connects patients to care within days, where traditional dermatology often has month-long wait times. Zest also works to cut spending in this pricey segment. They only enter into value-based arrangements. We're excited to have Olivia with us today to discuss her mission to transform this high-spend specialty through a value-based model and what she calls the, quote, de-prescription paradigm, end quote. Welcome to Moving to Value Unscripted, Olivia.
Thank you so much, John. You described my business so well. I feel like I need to co-opt those words for future uses.
Yeah, and listen, we're very happy to have you join us today, and I think it's great, and we all have a lot of questions for you. But before that, it's a tradition to kind of ask our guests to tell us a little bit about their life journey, and I kind of almost covered some of that in here, but it's interesting. Last week we spoke with someone who had 40 years of experience. And, you obviously have a much shorter career to date, although I have a feeling, if I'm still
Yeah.
alive 20 or 30 years from now, we'd be interviewing you again. But tell us a little bit about your journey, how you got from, where you were from birth to where you are today.
Yeah, no, I appreciate it. And I'll say it's always a funny quip working in the world of dermatology that you never know anyone's real age. And so you've given away a little bit of my cover that I am, certainly a young entrepreneur excited to innovate in healthcare and hoping to spend decades and decades more of fixing the many problems we have. But my story starts in a beautiful healthcare city in America, which is Cleveland, Ohio. And I am a huge advocate for the amazing talent and healthcare workers across the many fabulous health systems of Cleveland. So I grew up just drenched in that environment, the excellence of the Cleveland Clinic and UH hospitals, and quickly caught the bug of knowing I wanted to be in the healthcare space. I think I went through the phase that many do where they, as folks on this call can agree, felt being a healthcare provider would be my path. But I caught the entrepreneurship bug while an undergrad at Duke and realized I really wanted to innovate, that I could touch more people by creating new biomedical innovations than I could as a standalone health provider. And so pivoted from there, did some research at Stanford, and then got tapped to join a company that was actively disrupting in the healthcare space. That company, Roivant Sciences, was built from the mission to bring kind of new voices into drug development and new technologies into drug development. We know that therapeutic development is incredibly expensive. It's slow. It's hard to translate science into functional medicines that create an impact in our healthcare system. And Roivant was committed to bringing fresh voices into the space in order to develop drugs faster, better, and more efficiently. And so joined that company, which really embedded in me a sense that young innovators are the future of healthcare. And we need to engage young innovators in the healthcare space in order to drive lasting multi-decade of change in healthcare. And so I was surrounded by coworkers who were mostly in their 20s and 30s, but very mission driven about revolutionizing biotech development. And while I was there, I was also handed a lot of really cool responsibility very early on. the founder of the company, Vivek, was young himself and did not see age as a prohibitive factor to being able to make an impact. And that stuck with me through even today. And so I had the opportunity to personally launch a couple new biotech companies for the platform across different specialty areas. I also served in our foundational M&A team, where I led about $3.5 billion worth of deals, including one of the largest pharma deals of 2019. And was just really honored to be given that level of access and that level of rapid learning to how healthcare works and also how healthcare doesn't work. And took those learnings and, about 2 years ago, started my company now, Zest, feeling, a bit unsure, candidly, about if the timing was right. There's certainly folks in healthcare who have been around for decades and decades and, wait till they have that kind of moment of epiphany where all the stars align to start a value-based healthcare company. I felt so passionate about my personal connection to dermatology that I just needed to take the leap and start Zest at that point, even though in many ways I was not ready as an entrepreneur. I don't know if you're ever ready as an entrepreneur, candidly, but decided to take that leap because I had suffered so deeply from psoriasis. I was living in New York City at the time. I was stressed working M&A deals in biotech for a really fast growing company that, when I joined was small. And by the time I left had IPO'd and gone public. And I think the stress and factors of my life led me to meaningfully flare with psoriasis. My skin was cracking, bloody, itchy. It hurt to wear my work clothes. I had trouble sleeping at night. And it was impacting my life meaningfully. And when I wanted to receive dermatology care in the middle of New York City, I found that it was going to take over 6 months to get in with a practice and receive care. Then when I got to the office, it was a 20-something second appointment with a dermatology, physician assistant, where I did not feel like I had meaningful relief. And the stars really aligned in that moment. I had a close family member with psoriasis and psoriatic arthritis, which is the associated inflammatory joint condition. And I heard these frustrations as well, but to live them firsthand, felt as though there was an opportunity to create a company that would change dermatology and leverage my background in biotech and drug development to really understand how prescriptions were in the status quo influencing dermatology care.
Wow. John and Laura, we've heard so many of our guests give their personal story, and there's some common theme there, Olivia, that there's something, firstly, deeply personal, and oftentimes just a sense of looking for a better way. There's something intrinsic,
Yep.
right, that you just want to have an impact and find a better way. But we've spoken a few times before, and by the way, congratulations on a slice of healthcare, 50 under 50, but in your case, it might be 50 under, we don't know, maybe even 30. I don't know. Congratulations.
I am under 30,
There
but
you go. It wouldn't
That's a
be
30 under 30 then. She falls in.
Congratulations on that.
thank you.
But it sounds like from the beginning, you have a personal story and you wanted to solve some problems with your company. But why don't you, for the listeners, what were the problems that you set out to fix when you launched Zest?
Yeah, absolutely. I think there are two main categories of problems facing dermatology care today. And I'm going to start with the dermatology provider industry at large, which is that dermatology care has dramatically changed over the last decade. I think anyone could see with the naked eye that aesthetics, elective dermatology, there's a couple words for it, cosmetic dermatology, you name it, has grown heavily as a field. The uptake of Botox, filler, laser treatments has created a large market opportunity for dermatology practices to bring their clinical expertise to a space that has some shady dealings. They can bring a real reputation and brand behind it that patients are drawn to. And so many dermatology clinics have gone from, being heavily fee-for-service driven to now having significant portions of their practice profitable through cash pay cosmetic procedures. And so that's one change. In accordance with this, private equity has been very active in the dermatology space in consolidating and aggregating derm practices, changing the makeup of the schedule, changing the makeup of the staff, and I think shifting priority slightly to drive profit as well in the practice. And I think third piece is that the healthcare system has increased the amount of work and friction for caring for chronic derm patients. So a dermatologist now has to fill out significant paperwork related to prior authorizations on the therapeutics used for patients like me with psoriasis. And so all of those elements come together in concert to create really strong financial incentives for dermatology practices to lean into cosmetic elective care, lean into high margin procedural care like biopsies, but lean out of chronic dermatology care. And to illustrate that, imagine you have a patient come into your office and they need 30 seconds of Botox injections, and there's thousands of dollars on the table there. In contrast, a chronic dermatology patient with eczema, psoriasis, rosacea, vitiligo, you name it, could go into the office and require clinically 15 to 30 minutes of thoughtful discussion about what could be triggering their disease. What are they eating? How hot is the temperature of their shower? Discuss the very complex and vast treatment landscape, et cetera. And that just time isn't financially viable or available to dermatology practices. I strongly believe dermatology providers want to deliver that quality of care. I hear that repeatedly, but it's not financially incentivized. And so that is kind of piece one. And then quickly, the second piece of that is that results in extremely high cost drugs for chronic dermatology being used much earlier in the treatment cycle, being used excessively and being used chronically. And that class of drugs typically are biologics. So injectable, immune suppressing therapeutics. I'm sure anyone listening has seen an advertisement for one of these products as they're watching, the nightly news. If you watch the Game Show Network, it's just riddled with biologics advertisements.
We could sing their jingles,
Exactly. I know. I will, live this, sing this, dancing, my skin gets clear. It's a very idealistic, rosy view of the prescription process for patients on those drugs. And in reality, these are fantastic therapeutics. They have high efficacy, meaning that they clear skin, but they are not clinically appropriate for every chronic dermatology patient. But they're being used in more and more patients as dermatology practices just need to get chronic patients' skin clear and out of the office so that they don't lose even more money on the chronic patient care experience. And those, to me, are the two problems: is we have patients not getting the quality of care they need to manage their chronic derm condition. And in accordance with that, patients being inappropriately on the fast track to pretty intense therapeutics that they might not need.
Right. That's a great point. When I used to run the residency program, and Steve knows this, as hard as it is to get into an orthopedic residency program, it was harder to get into a dermatology residency program because they have limited their supply actually for several decades. I used to, even literally 20 years ago, I said to myself, they're going to get themselves out of the market because, once you narrow yourself so much, where it takes months and months, and Steve knows this, and I know this from my own family, I've tried to get patients in this community into dermatologists. These are former medical students of mine, and I have to beg them to see somebody within 6 months. So that supply and demand mismatch is a contributing factor to it. But I think the other point you made, which I think is really important, is that many of these conditions, the first treatment, if you will, really should be non-pharmacologic, right? There's things like you alluded to, right?
It's a stress. What's your diet like? Maybe it's some dairy product type thing, some pro-inflammatory things that you're eating, ingesting. You're not getting enough sleep. It's the non-pharmacological interventions, which take some time, to your point. You got to sit and chit chat. You got to talk about it. Let's try this. Let's try that. But you hit it right on the head. It's always got time for that today. Even if they
Yeah.
know what I just said, by the way, about the lifestyle interventions you could do, I think that it's so much easier to say, okay, I'm going to get you on I won't name the brands here. I don't need to promote them anymore than they're already promoted on
Yeah.
television, which is every 3 minutes. Yeah, and I think it's a great story. I'm sorry, Laura.
Oh yeah, I was just gonna say, Olivia, could you tell us a little bit about how Zest does that, right? Like that shift
Yeah.
away. I know something you mentioned in our prep call that we had in the intro was this deprescription paradigm, and you've highlighted how, these
Yeah.
therapeutics might not be appropriate for everyone. What does that process look like for a patient?
Yeah. So first, I'll just start by laying the foundation that patients want relief from their disease. They are very open-minded on the path to getting to that relief, but their North Star is relief. And so, studies have shown that patients are open to biologics, but only want them as needed. And that is really core to what we do on our platform. So we do run a virtual dermatology clinic where patients can get seen. They get seen within a day. Typically, we see them very frequently, every 4 to 6 weeks. Those visits are 30 to 60 minutes long, as they should be, to really consult the patient and engage them in shared decision making. And all of that really alleviates the meaningful access problems in derm. But when we treat those patients, then we bring a very vast toolkit of therapeutic interventions into the analysis of what is appropriate for the patient. It may be that that patient should change their laundry detergent in addition to remaining on whatever therapeutic they're on. See if that helps alleviate things, just moving to a $6, unscented laundry detergent before we initiate that patient onto a $90,000 therapeutic where they're going to have to be at home injecting a drug into themselves, managing the side effects, and feeling like that's the only answer. And so what we do is really engage the patient on the fact that that is not the only answer. There are other options on the table that have to be in a personalized manner, assessed, applied, and then regulated, watched, monitored by our team so that we can make sure the patient gets to relief. And so what that looks like, I'll give a couple examples, is there might be a patient who comes to us on a biologic, and this is something we see all the time. They've been on that biologic for 7 years. 6 of those 7 years, they've seen no disease. Like they have no flares. We see this in psoriasis. We see this in eczema. And they've been told that that's because of the biologic. The biologic is keeping their disease at bay. That could be true. I think that is a possibility, but there's also a very equally as viable possibility that that patient just no longer has active disease. And maybe they quit smoking in those 6 years, lost weight, moved to a new pollution environment, changed their, shower water quality. Like it could be so many things. Healthcare is so complicated. And so we have a safe way for assessing if that patient can receive a drug holiday. Like let's safely ramp that patient off of this therapeutic, give them the tools they need so they feel supported if they do see a flare outbreak, give them the infrastructure to feel that we'll be responsive if they flare again. And if they don't, give the patient almost a best case scenario, which is you don't need to actively be on therapeutic right now. You don't have active disease, and therefore we're not going to put you on active therapeutic and allow you to just live your life without the burden of monitoring this therapeutic decision that was made years ago. And so that is just one example, but it's an example of how we approach deprescription, which is when it is in the best interest of the patient and we're able to give them a lower intensity daily load of their disease, make them think about their disease less, candidly.
Olivia, I had a rash a couple of months ago. I was a primary care doc. I didn't tell you that. And
I didn't know that.
In the tropics. So I saw a lot of skin and I got comfortable. In fact, I picked up a case of leprosy. I remember that. Looked So they sent it to me with acne. It turned out to be leprosy. But I had a rash. I called my primary care doc. The typical answer was go to the urgent care. I said,
Mm,
there's no way. So I said, I went online, took a picture, and for $35, they said, yeah, it is ringworm. Go get some Lotrimin, and it was gone. So,
yep.
but the scenario you described is emblematic of not just of dermatology, but it's the misaligned incentives that are associated with fee for service. There is no benefit to a dermatologist taking the time to do what you describe. It just is not economically feasible. So they're not bad people. It's a bad system.
Yep.
My question for you in your business model to dive into that a bit, how do you find dermatologists to staff your clinic and how are they compensated? That would take them away from the Botox and all the other stuff.
Yeah, no, it's a great question. I know there are other, virtual clinics that face abrasion or challenges in recruiting mission aligned providers. I'll be honest in saying I don't think we face that as a company because we find that many derm providers are really wanting to deliver this level of care. Often one of the first things I share with providers is, hey, you're going to have the opportunity to have 30 to 60-minute long encounters with the patient. And you can actively see something click for the provider in that moment of, wow, that would be so nice. That would be so nice to be able to awarded the time to have deeper conversations and also develop more trust and a deeper relationship with the patient. I generally think in healthcare, we undervalue the commodity of trust. Trust enables you to say to a patient, hey, I know it's going to be scary to discontinue this drug, but I think it's really clinically appropriate and the right choice for you. That requires trust. And I think many derm providers see the ailments that chronic derm patients face and feel strong empathy and love that there are new financial models like value-based care that enable them to deliver more compassionate and high touch, hands-on care. And so it's not something that we've, heavily faced. I do think that there are some derms through training mostly who love biologics because it's a little bit less work for them. And while I think that that's a perspective, when you sit across a table from a provider like that, it's very quick to get to the root cause, which is not their clinical philosophy or clinical dogma. It's really that training and training within the fee-for-service system has incentivized that behavior. And so I'm candidly very optimistic about where dermatology as a field can go if we can put in place value-based care rails.
I wish I were a dermatologist about to retire or retired, because I think for a retiring dermatologist, this seems like a nirvana of an opportunity. And just to complete the thought on the business model, just so I fully understand it. And I guess for the continuing care, if I understand correctly, almost all of your patients have already been diagnosed. So we don't have to worry about the biopsies and the dermatopathology component to this business. They've already been diagnosed. They're already on a very expensive drug most of the time. And now we're in that phase of, you don't really need to be on it that much. We could really reduce the costs. And let's talk about all the other factors. So I get that. Although I would argue that there's a huge opportunity to expand to include even things like Steve was alluding to from the provider side of your physicians or PAs or whoever you have in the mix, because you don't need physicians actually to do a lot of what we just talked about. They get paid like on a per click model. And I also want to flip to the other side. So who's your client? Are they primary care groups? Are they integrated clinical delivery networks? All the above? So both answers. How do those guys get compensated? And then who's your market?
Yeah, on compensation, I will this will be a little soft and squishy, and so I apologize, but I just really want new providers that come into my clinic to feel really mission aligned and a part of our broader family. I think that that is one of the things we try to deliver to our patients is just more compassion and warmth. And so maybe different than many other virtual care platforms, we actually prefer a model that ramps our providers into full time on our platform. there are a lot of dermatologists who kind of spend an hour each day on this telederm platform, a couple hours here, 3 hours here. And I worry about the volume burden that places on those providers and how much connection those providers can feel to any one platform and that platform's care philosophy. And so what we typically do is start our providers on, minimum hours with an hourly rate, but very clearly communicating that like our intention is to move towards full time, because if we feel aligned and we like being coworkers in many ways, then we want to invest in that relationship and invest in our care philosophy growing, adapting, and being spread to our patients effectively through our dedicated team. And so that is a business model decision that I made that so far has really paid off. We just have like a fantastic clinical team that cares about the Zest clinic, not just receiving the hourly rate. They care about the clinic. And on the kind of who is our customer, our partner,
Right.
I think there are a lot of folks in healthcare who have a vested interest in A, improving access, B, improving outcomes, and C, reducing spend. And that tends to be our target partner. The reason we partner with folks like that is because they are able to facilitate the delivery of our innovative product to the largest number of patients who need it. And so we partner directly with employers who take risk, health plans, and the brokers that facilitate, many of the connections in the field. And those partners enable us to deliver our product and deliver it in a value-based care setting where we get compensated, not when we have an appointment, not when we send a chat message, because that's not actually delivering value to the patient. We get paid when we deliver real, tangible value.
Olivia, I want to come back to, you touched on a couple of words here. So this morning I listened to Stacy's podcast, Relentless Health Value, Dr. Bajaj. It brought up something that you're tapping into, which is really the whole idea of purpose. I think when they ask folks about what might keep them with their current company, it was pride in work and connection with colleagues based in trust. And you've tapped into that at a young stage in your entrepreneurial career, which is really remarkable. But I do think the folks that you've been able to cultivate to join your team probably share that same purpose and may not suffer from that condition that's now called chronic moral hazard. So good for you. I mean, it's a tough slog, but get those people on your bus and you're really positioned very, very well, I think. John,
Yeah, no, I have to agree. I'm curious about where you are in your growth trajectory because I know you're literally a startup and it's been only a couple of years. But I think you hit on something. There are people. Listen, Steve, this is our whole existence now. There are people out there who are exactly focused on things that we've just talked about: reducing costs, improving quality, improving outcomes, changing this crazy freaking system. And dermatology's got to be almost whatever the opposite of gold standard is of how bad it can get, where you can't get in to see a provider. It's incredibly high. These are amongst the highest cost drugs. And unlike cancer, these are chronic relapsing remitting conditions in almost all cases that also have a non-biological basis. They're biological, but a non-pharmacological interventions that can be happening. I mean, I would argue that's probably true even in cancer, but it's far clearer in your case. Like you said, I mean, changing your soap, changing your detergents, and don't sit in a really hot shower for 30 minutes, which is, kind of like basic stuff that a lot of people just don't have a freaking clue about. And they've dehydrated their skin, and then of course they're hypersensitive to anything, and then you add a few other factors, and then boom, all of a sudden you have this flare. I just worry about the growth. I just think you're going to grow fast, and I think it's easy to expand. But right now, there's a huge, we've had a lot of pharmacy folks on our podcast, and this. America has 4% of the world's population spends 50% of the total healthcare. But then when you break it down and looking at the actual what the healthcare spend from an employer's point of view, a big chunk of it, probably about a third, is on pharmacology. And when you look at the pharmacology spend, a handful of drugs account for half of the spend. So we're
Yeah.
talking a huge amount of money. And then when you look at that handful, just a couple of products in your space account for a big chunk of the cost, right?
Yeah, I mean, I am always astounded by this statistic, but we're approaching 50% of our total US pharmacy spend being on biologics.
Yeah.
Half of our spend coming from biologics. And, granted, those products are used across, autoimmune conditions and, have other clinical purposes. But I think we need to be creative about how to address that spend and also clear-eyed about why that spend is growing. It implicates some of the complicated, dark, pharmacy incentives that we all could talk about in this conversation. Higher cost drugs carry higher rebates, et cetera. But I think it also implicates, and I love you're saying what's the opposite of the gold standard. I was trying to think, maybe it's the coal standard.
Yeah.
But the coal standard being, dermatology, I think if I had to simplify or deduce it into one sentence, it's that dermatology treats chronic patients, but doesn't treat them in a chronic care setting.
That's a great statement.
And where, to your point, oncology, we, know that those are acute, high intensity moments for patients. And I think we've built a system around those acute moments. Dermatology has not adapted to build around the chronic care experience. And that's where I'm excited. And I appreciate you saying we'll grow fast, but I'm excited to really shepherd dermatology and be a voice and advocate for dermatology in the what I call the value-based era. I'm very bullish on our healthcare system needing to move to value and hence moving to value, as I know you all can agree per the words. But I don't want dermatology to be left behind in that transition, because there is a lot of value on the table for providers to create and apply a chronic care model to chronic care patients, and thus reduce that 50% of our healthcare spend that's going towards drugs that don't need to be deployed as frequently as they are.
Can you give us an example of one of your clients' success stories regarding what you've been able to save them?
Yeah, absolutely. So maybe I'll speak to a client where how we structured that particular partnership is we went straight to the highest need. And that highest need was patients who were at that point, we'll call it today, patients today that are on a high cost drug for their psoriasis and eczema. These are going to be, patients that absolutely require a chronic care model. There was some impetus, even if it may have been at the time clinically inappropriate, but some impetus to put them on this pretty intense drug. And so we started there and reached out to let those patients know that they could get seen on our platform, that we would still maintain a relationship if they had one with their derm. We love partnering with dermatologists, and that if that patient needs a brick and mortar need, we want there to be a brick and mortar source of care that the patient trusts and can access. And so we will kind of keep that orbit, but we can treat their psoriasis and eczema needs. And so that is a partnership model to me that really cuts straight to, can we produce the value that we claim to produce, which is folks who are on high intensity drugs. And so when we stepped into that group, we deprescribed for 66% of those patients. Wow. And what that said to me when I first saw that stat, it's just, wow, so many patients are inappropriately on biologics. A large majority of those patients, we transitioned to a drug holiday, meaning they just didn't need to be on anything. In some cases, we gave them what we call a rescue topical corticosteroid, which is just hey, have this tube. And if you need it, this gives you comfort that you have something if there's, breakthroughs. And then in our product, we just have a big button that says, I'm flaring. And if for whatever reason you start to see your skin disease come back, you click that button and you have an appointment the next day with a provider to assess what the right path is. And so I was really proud of that partnership just because the impact we had on the patient experience. 91% of those patients said they preferred us to their kind of prior derm interactions and experiences.
Wow. Pretty good
that
net
was
promoter score.
I was about to say it was
Wow.
a really, really proud moment for us as a company because, and not to beat this drum too heavily, but when you are in the value-based care space, you need to see metrics like that to know it's worth building your company and continuing to grow your company. You feel aligned with those metrics, feel aligned with the patient experience, patient happiness. And I think that was just a special moment to feel like, wow, we are really able to do what our mission sets out to do.
Great.
That's incredible. Yeah. What the metrics that you do look at, what does Zest use to kind of, of course, spending, you mentioned like deprescription and like satisfaction. Are there other things that you take into consideration?
Yeah, I could talk your ear off on this. I will say, and this goes back to my background, but coming from the world of biotech, it was candidly very alarming to me to enter the world of digital health and see the low fidelity to gold standard clinical metrics. And I believe as a value-based movement, we should encourage ourselves and our colleagues to measure gold standard metrics because that is how we build credibility for value-based offerings. And so that was important to me. And so I was very familiar with what the kind of gold standard metrics were for psoriasis and eczema, and we implemented those. And so in all of our patients, we measure body surface area. So what percent of the patient's body is covered in disease. We measure PGA or IGA values, which is a kind of the FDA validated way of measuring severity of psoriasis and eczema. And then the most important one to me is we measure a gold standard quality of life metric called DLQI, the Dermatology Life Quality Index. This is the metric in dermatology for how much is the disease impacting the patient's life. And it's remarkable with skin diseases, how much resilience you see patients have. Patients come in and they might have 15% body surface area, which if you are listening and want to imagine that, your hand, the surface of the palm of your hand is approximately 1% of your body surface area. So imagine 15 hands of disease active on your body. And sometimes those patients report really low scores on the quality of life index, meaning they're doing great. Like they don't think their disease impacts their life. Conversely, there are patients who have small patches of disease, what we would classify as low severity on the PGA scale, but have very high DLQI scores. It's really impacting their life. Maybe it's on their knuckles and they work a job with their hands. And each time they have to bend their knuckles, it cracks and it hurts and it impacts their ability to do their job successfully. And we really use that DLQI score as a North Star for our organization while capturing the clinical scores as well. Like we do want to improve disease and we do. But on DLQI, we're just very, very proud to make a rapid impact. By the first visit, we're already seeing the majority of our patients have a DLQI reduction.
Wow.
And that means that we are impacting the lives of patients through our clinic. And I really encourage other virtual care companies to do this same analysis and look at what are the metrics that get drugs approved. How can we apply those metrics to our product so that we can show clinical efficacy on par or exceeding purely therapeutic interventions?
Makes sense.
That last metric, DLQI, that's patient reported, patient derived?
So it is a survey that is administered by the provider to the patient. And so it is a guided survey and we administer it in the clinically standard approach that the FDA requires, which I think is just important to us for data cleanliness.
Interesting.
Yeah.
Yeah, no, that makes a lot of sense. I never heard of it before, but it makes a lot of sense, of course.
And I think it's interesting, I'll add that you don't tend to see DLQI scores reported for a lot of biologics. It's not really what they measure typically is the quality of life impact. I do think biologics probably do have a quality of life impact, but that's certainly not their North Star. It is, however, at our clinic, our North Star is quality of life for the patient.
It's interesting. I used to work, I guess I technically still am a contractor for the FDA, one little committee, which is a microbiologic device evaluation committee. But I did learn a lot in my time with that, was that, it doesn't take much to get approved by the FDA because they're primarily worried about safety. So as long as the drug's not really killing people, you're pretty much going to get things approved. So I always watch those ads and I always read the little fine print that's scrolling along the bottom of the screen. We look at the efficacy of the drug compared to placebo in what percentage of patients. And a lot of these drugs are, I get it. Believe me, for the right patient, they're merely effective. But, compared to a lot of other stuff, they're not necessarily all that more effective than a much less expensive alternative or even a non-pharmacological alternative. And it's kind of crazy, right? But for the right patient, to your point, right? Some of these things they're life-changing.
Yeah, I mean, I will self-identify as being an FDA fan just broadly, which is like, I think it is really good that we have, a nonpartisan regulating body for the medications in our country. And I think it's important. I've heard, and this gets into kind of, conjecture, but I've heard people advocate that the FDA should formally do exactly what you outlined, John, which is approve any drug that doesn't hurt people. And then folks can decide, in shared decision making or through their clinical practice, how they want to apply those drugs. It's an interesting model. I do think that we need, my personal perspective is we should continue to hold a high bar for efficacy. That's, fundamentally, and this gets into kind of the psychology of care, but there's just a set number of shots on goal for a patient to find relief. It's exhausting if you're a chronic care patient to continue to try things and not get relief. It's exhausting. And there's kind of that opportunity and willingness to try lost at each step along the way. And so if we really try to find and deploy products that work for the patient and support them through that process, then you can really get relief for the patient without losing their, kind of demotivating them along the way. And that's why efficacy is important for patients. And so I agree there. And I think that's important to our perspective on prescription. Like we do prescribe on our platform. There are virtual care companies that do fully lifestyle. We prescribe because in our disease states, you do need prescriptions as a tool to help the patient receive relief. There's a whole slew of other things.
You may not need it as long or continuously as probably your biggest describing
Absolutely.
part.
Or for every patient. But I think it's important that we continue to maintain trust in our, therapeutics market because we want our patients to also have openness to things that will give them relief.
Olivia, we started with trust and we'll end with trust. And John and Laura and I have many, many questions. We'd like to follow up with you because you're clearly on the right track. We're very, very impressed. But we have a little tradition here on the Unscripted podcast to ask our guests to put on their visionary hat, the little blue sky thing here. So 2 parts of the question. What are the key trends you see in your industry, specifically in dermatology, the application of Gen AI and so forth, over the next 3 to 5 years? And part B, equally important, how do you see the new models of derm playing into the bigger population health management, at-risk primary care as this unfolds in the next 3 to 5 years?
Yeah. So
small question.
I know, small questions, but I think my answer to both questions may be the same, which is I believe we are going to empower primary care physicians to deliver more dermatology supportive services. I think it's actually really important that we do so. And so one example in derm is there are kind of fabulous innovators in the derm tech world who have built image-based triage tools. So take an image of a suspicious mole and it will, with relatively good certainty, tell you if that's something you should be worried about and you should biopsy or investigate further. And I love tools and love the direction of tools like that because I envision that being able to empower primary care to catch things earlier and not rely on the derm access point to get those answers. Because as we know, and we've talked about, the derm access point isn't easy to access. it's hard to get an appointment and it's hard to get the time in that appointment to get seen. And so I'm really interested in ways that derm technology innovators can support bringing primary care into the conversation, potentially even upskilling primary care on that biopsy. I think primary care would be potentially open to additional revenue streams as it relates to those services, but doesn't quite have the training tools in-house and at large to deliver on that. And so that is something we have done at Zest, is kind of talk to primary care clinics about the best ways that they can support and triage their own patients, and in particular, value-based primary care clinics, engage and triage their own patients so that they're driving the outcomes that they're measured against. And we are just seeing better brick and mortar care getting delivered to dermatology patients. And so that is my kind of future of derm, but also future of bringing other healthcare services. I will add one, which is not directly related to your question, but just a general healthcare prediction, which is, I think when it comes to pharmacy spend, we are just learning that traditional for folks listening, being utilization management. So the practice of formulary design, prior auths on drugs, quantity limits, you name it. There's a whole kind of slew of levers that we pull traditionally to try and, control costs in pharmacy, but also control what patients can access.
Right.
I think there's a lot of scrutiny on those practices. I think they erode trust in healthcare. And I really envision that value-based care is the answer. It's actually a way to deregulate a lot of what we currently regulate around access. Let's take those regulations away, because we have more and more providers that are aligned with the mission of utilization management. They are aligned with making clinically appropriate prescription decisions. In fact, they're measured against that metric. And when you align the provider with the formulary, you don't need to add paperwork and friction in an idealistic world. And so that is just my broader healthcare prediction, is that as we shift to more value, we'll also be able to just remove regulation and increase access to therapeutics for our patients.
Wow, that's a great answer. That sounds like that should have been on our billboard of the Moving to Value Alliance. Olivia, I couldn't have said it better.
You're happy to steal it, John. If I can steal your
Yeah.
intro about Zest, we'll do a swap.
No, it's we're really grateful that you joined us today, and honestly, we're collectively excited about your future, not just as an individual and an entrepreneur, but the model of Zest, I think, has a lot of opportunities, and we probably could think of a handful of other entities that are not so dissimilar. But I think you've picked a perfect space, actually, to get started, and there's nothing but bright future ahead for you. At the end of the day, you're doing what we would call, our golden mantra, which is improve outcome for patients and lower the cost. And you can get, better outcomes at lower cost. This is the holy grail that Elizabeth Teisberg and Michael Porter wrote about now, 15 years ago. You're a good step in the right direction. So thank you so much for joining us today. And Steve and Laura, of course, as always, been a pleasure. And I wish you well. We got a feeling we'll be seeing you again, Olivia.
Thank you. And I hope so. Keep in touch.
We want to take a minute now to introduce the new MTVA membership program. As a 501c3 nonprofit, we rely on support from our grassroots network to advance our mission of creating a value-based health system with high-quality patient outcomes at a reasonable cost. As we continue to grow and broaden our impact, we're excited to invite like-minded organizations and individuals to join our membership program. Tax-deductible membership contributions help us enrich the healthcare environment with quality content, including this podcast, and robust platforms to fuel discussion, collaboration, and advocacy that lead to groundbreaking solutions. For more information, visit our website at www.movingtovalue.org/trade member. The link is also in the episode description. Thanks again for listening and for being part of this important movement.